to introduce Dr. Artur Petrosyan. He will be presenting on radioembolization of intrahepatic cholangiocarcinoma, New Horizons. Thank you.
I'm sorry. Dear Professor Ahmed, dear colleagues, thank you very much for the invitation. It's a great honor for me to participate in this great conference. And first of all, I would like to say a few words about our institute, National Medical Research Radiological Center, one of the largest oncological and radiological centers in Russia, with 3 branches, 2 in Moscow and 1 in Obninsk city. I work in Obninsk, which is Russia's first science city, and the world's first nuclear power plant opened in Obninsk in 1954. Historically, our institute, our center in Obninsk has been a leader in nuclear medicine. In Russia, we used all types of radionuclide therapy. And our Department of Interventional Radiology is opened in 2018. And our director, a chief oncologist in Russia, instructed us to introduce the radioembolization method into the Russian healthcare. By the way, Professor Kaprin studied in Mansur Center in Egypt and always speaks warmly about Egyptland and Professor Gunim. And so, why the chief oncologist of Russia interested in radioembolization? Firstly, because it's a more effective method, and secondly, because it was not in Russia. And we started producing our microspheres, and now we have 2 types of microspheres in Russia. Today, our department is a leader of interventional radiology in our country. We performed more than 2.5 operating and more than 150 radioembolization annually. And let's come to cholangiocarcinoma. So cholangiocarcinoma, it's a rare but very aggressive tumor. And in my presentation, of course, I talk only about intrahepatic forms of cholangiocarcinoma. And so the clinical recommendation from all over the world, including Russia, say that we can use radioembolization in the treatment of cholangiocarcinoma. But the treatment of cholangiocarcinoma was presented in more detail in the publication of the International Consensus Consortium. And please know that these articles published 8 days ago. And the radioembolization is highlighted in a separate column. Clinical recommendations are based on many studies, but if we pay attention, we will see that the results of radioembolization are comparable to the results of systemic therapy. Therefore, the main question is how can we improve survival outcomes in patients with intrahepatic cholangiocarcinoma? Is the location of the tumor important? Yes, it is. Is the tumor neoangiogenesis important? Sure, but the hepatic artery anatomic variants are more important. Is the radionuclide important? The answer is yes, because the nuclear and physical properties of isotopes used in radioembolization differ. We all know that the half-life is an important factor for logistics, but more importantly, that the half-life is an important more important in terms of radiation dose. And of course, we understand that Y19 is an almost perfect radioisotope. Then other questions. Is the type of microspheres important? Again, the answer is yes, because different microspheres have different parameters. Dear colleagues, you understand I'm talking about personalized dosimetry that based on individual parameters of particular patient. And when we use personalized dosimetry, we can get an objective response from 100% of cases. Another important question, is it worth combining radioembolization with systematic therapy? Again, it is. The MISFEC study has shown that it is safe and more effective. One more thing I want to mention in this article of International Working Group, because there are very detailed recommendations on radioembolization of intrahepatic carcinoma. And now about our results. We have completed the single-center non-randomized prospective study of liver radioembolization by yttrium-90 microspheres in patients with intrahepatic cholangiocarcinoma after progression to 2 lines of systemic therapy. And it's our result: partial response 40%, stable disease 35%, progressive disease 25%, median overall survival 30 months. Analyzing global research data and our own results, we have created our own algorithm for the treatment of patients with intrahepatic cholangiocarcinoma. And in this year, we start multi-center prospective clinical trials of the use of radioembolization with yttrium-90 microspheres in combination with first-line systemic therapy for intrahepatic cholangiocarcinoma. And now, some cases. First patient, 74 years old man, with a big tumor in the left lobe of the liver, delivered 200 gray, and after 6 months, partial response, and patient continued systemic therapy. Next patient, 70 years old woman with a tumor in the first segment, and 120 gray delivered, and complete response 2 years. And it's a very interesting patient, 53 years old man with a large, big tumor in the right lobe of the liver, and echo is 0. Angiogram shows a big zone neovascularization in the right lobe. And we delivered 400 gray in the tumor. And this is CT show results after 3 months. We can see the total necrosis of the tumor and planning surgery. So the first step, we make portal vein embolization, and after that, right hemihepatectomy. This is CT scan after 1 month of the operating, and patient go home and feel good. So in conclusion, I would like to say that radioembolization of the liver in intrahepatic cholangiocarcinoma is a good method of the choice for local disease control. Personalized dosimetry is a key to improving treatment outcomes, and the combination of TAER with systematic therapy is the best choice for any tumor board. Thank you so much for your attention.
Thank you very much, Dr. Artur. And now, allow me to introduce the second speaker.